Hi, I'm Genevieve Goulding and I'm an anaesthesiologist from Australia. I live in the beautiful riverside city of Brisbane on the East Coast. In another session, a previous speaker has outlined burnout from etiology to intervention. In this talk, I'll run briefly through a definition, outline the drivers, give you some idea around the incidence, and then the burden of cost. And finally, a few words on the impact of the pandemic. As you are mostly aware, the syndrome of burnout was first defined in 1974 by Freudenberger, a New York City psychoanalyst, and he defined it as a state of mental and physical exhaustion caused by one's professional life. Meanwhile, on the West Coast over in California around the same time, Professor Christina Maslach from California was also researching the syndrome, and she published the Maslach Burnout Inventory in 1981 with a well-described triad of emotional exhaustion, depersonalization, and personal accomplishment, which was diminishing. In 1999, Leiter published his Areas of Work-Life survey, which identifies 6 key elements of work. These are workload, control, reward, community, fairness, and values. And this survey is used to identify the gaps between an employer's expectations and the worker's expectations and experience. It is this tension between the two that contributes to burnout. Since that time, Maslach and Leiter have collaborated many times and published on the complex interplay between the areas of work life and the 3 aspects of the Maslach burnout indices. And the two are usually used together as predictors of burnout as well as a guide to mediation. There are other tools as well. This is quite a well-known one. This is the Copenhagen Burnout Inventory, which was devised in 2005. And it has 19 questions addressing work-related and client-related issues, as well as personal burnout. And this is available in at least 8 languages. The World Health Organization incorporated burnout into its International Classification of Diseases in 2010. And in 2019, they expanded the definition in ICD-11. It is clearly stated that it is due to chronic workplace stress that has not been adequately managed. And it makes it also very clear that it is specific to work. This book on burnout was published this year, and its author, Professor Gordon Parker, is a professor in Sydney in Australia, and I commend it to you. He writes first about the Sydney studies, which were 2 observational studies on over 1,600 subjects experiencing burnout. These are the 12 most common symptoms reported. I like this list because it is something that I think practitioners can easily relate to as what they're experiencing and feeling. From these, his team developed the Sydney Burnout Measure, which was published in 2020, which has 34 questions across 6 domains. I'd like to bring your attention to the last 2 points. Firstly, that burnout is not depression, although the two may actually coexist in the same person. And lastly, that he has a very strong view that perfectionism is a key driver in the development of burnout. This useful table helps differentiate between burnout and major depression. There are some features in common, but there are also some important differences. Also note that burnout is not yet in the DSM, the Diagnostic and Statistical Manual of Disorders from the American Psychiatric Association. It is not yet recognized as a differentiated pathological entity. In some countries, it has been legitimized as a justification for sick leave, but it is not an illness or condition suitable for compensation, certainly not in the United States, UK, or Australia, as far as I'm aware. Parker describes burnout as a diathesis stress condition and somewhat like a seed that needs water and the right climate and soil conditions to grow. So predisposing internal factors interact with stressful events, which can then lead to this condition. It's important, therefore, to address internal as well as external factors. That is, the work environment, how we as practitioners react to our work stressors, and also perfectionistic traits in our personality. Most of you will be familiar with the expression, the canary in a coal mine. Years ago, miners used to take a canary in a cage into the mine tunnels. If the canary died, it was an indicator of toxic gases. In her book, Emotional Female, Dr. Yumiko Kodata, whose surgical career was cut short in its infancy by severe burnout, makes the point that it's not enough to make a canary more resilient. You have to address the toxic gases as well. That is, that external as well as internal factors are important. Dr. Dyke Drummond, MD, is the CEO and founder of thehappymd.com, which is an excellent online resource for managing burnout in doctors. And he says that these are the 4 universal causes of physician burnout: the practice of medicine itself, the job, what's going on in one's private life, and conditioning of the medical education process. The practice of medicine is clearly centered around patients, but patients come usually with attachments, such as a fetus or a family, and they have to be considered as well. In our work, we are frequently and constantly exposed to disease, to pain, anxiety, to fear, and occasionally bad news or outcomes. We have to manage patients and their families' expectations and biases, and these may conflict with our own. We may be frustrated by patients' poor lifestyle choices and the burden of disease that comes with that, or their non-compliance with our instructions or treatment. Then there's the job: rosters, irregular hours, extra hours, unpredictable finish times, shift work, workload, both in volume and complexity, documentation, which could be considerable and is often incredibly repetitive. We have to deal with bureaucracy and an increasing number of managers. Medicine is now a business, and there may be downward pressure to meet targets such as throughput, and there are endless meetings and reports and rounds. IT and frustration with IT is pervasive, and more often than not, the promised benefits of increased efficiency and access are outweighed by complexity, poorly integrated systems, or failures. And interconnectivity is also an intrusive burden. Increasingly, we find that it is constant, we are always contactable, and there's a blurring of work and personal life. The two can be very, very hard to separate because it's all on your phone or your tablet. Many doctors also feel that they've lost their professional autonomy. They feel like cogs in a wheel, that they are powerless, that they're not heard, that their contribution is not noticed or valued, and they feel disrespected by other members of staff, other clinicians, and patients. And often remuneration and recognition for extra hours work or effort is not forthcoming. This is a really nice little paper called The Electronic Elephant in the Room, and it's about IT in the medical workplace. What else is going on in one's private life? These are all powerful sources of stressors. Relationships, chores, quality time, caring duties, whether it's a partner, children, pets, aging parents, concurrent life events, marriage or divorce, a new baby, there may be bereavement or illness, renovating, repairs, moving house. People have study or teaching commitments. Finances may be an issue. Perhaps you have a medical legal issue running in the background. And then there are your own health issues. Do you actually have time to eat properly, to sleep, uninterrupted and deeply and long enough? Do you get time to exercise, to maintain your friends, to worship? Do you have time to be still? Finally, he talks about the conditioning of the medical process, the hidden curriculum, that is, what you've been taught medicine is versus how things really are at the coalface. There are many hidden curriculum messages in medicine. These are just some of them. Others include that there is a medical hierarchy, or that asking for help is a sign of weakness. You may also encounter gender inequity or other forms of discrimination in your workplace. The management of burnout will be covered by other speakers in this meeting, but it is important to note that there's no one-size-fits-all approach. It needs to be customized. Work stresses and personality factors all need to be addressed. It's crucial that the burnout victim has insight. It all starts with reflecting and answering the question, how did I get to here? These are Goulding Parker's Sydney Studies subjects' top 5 strategies for recovering from burnout. Talking to someone and seeking support, walking or some other form of exercise, but walking is incredibly beneficial, mindfulness and meditation, paying attention to sleep and developing a sleep hygiene routine, because exhaustion is the prominent feature of this syndrome, and that one may have to take time off or perhaps even leave work completely. Who can help? Well, clearly professional help is required. An empathic boss, an organizational psychologist might be required to assess the workplace culture and enforce the systemic change that may be required. And that may mean an adjustment in hours, in workflow, or your work setting. Stress reduction needs personal as well as work, wellness, and coaching strategies. And finally, addressing personality factors such as perfectionism probably requires assistance from a psychologist. Now, a word on perfectionism. Perfectionism is a common and desirable trait in doctors. It makes us dutiful, thorough, and striving for excellence. But it is a significant driver for burnout and can be counterproductive. So these 2 books are suggested practical references to develop strategies to overcome time-consuming and energy-consuming attention to detail and to help combat fear and procrastination. So how big a problem is this? This systematic review by Rotenstein et al. Found marked variability in the prevalence between 0 and 85%. But they did comment that there was marked variation in how burnout is defined and assessed, and also the study qualities of the papers they looked at. And they weren't able to find any significant correlations. However, generally, the incidence has been found to be somewhere between 35 and 50% of doctors, with females outnumbering men, round about 50 to 35, say, percent, and some subspecialty variation. So this is from the 2021 Medscape National Physician Burnout and Suicide Report. So this is American, and it was 15,000 doctors over 29 subspecialties. So this is a COVID year, and you can see that women exceed men, and you can see that the top subspecialty is critical care at 51%, with infectious disease not far behind at 49%. Anaesthesiology is halfway down at around about 40%. So what is the cost? Well, in dollar terms, it's huge. In the US, it's been estimated that physician burnout costs a staggering $4.6 billion per annum in reduced productivity and physician turnover. This cost is borne 3 ways. It's borne by organizations. When doctors are present in the workplace, but they are inefficient or underperforming and/or disruptive, or if they're absent, which may result in staff shortages so everyone else is working harder, or need costly recruitment processes and training and orientation of any replacements. The cost is also borne by the individuals experiencing burnout. So they're not only the misery that they're suffering, but also their relationships may suffer. And they may end up leaving a career that they absolutely love, that they've invested heavily in terms of money and time and training. And lastly, there's a cost to society. Safe patient care requires healthy doctors. And if a doctor leaves the profession, then society has lost that investment in their training, but has also lost their years of experience and expertise and passion. Significant resources are required with support from government, employers, and professional bodies to prevent and mitigate burnout and support affected doctors back into work. In the UK, the National Health Service, the NHS, has committed £19.5 million over 5 years into investment in wellness programs for doctors. Coronavirus. Coronavirus has been the game changer. Many studies from many countries over the last 18 months have shown very high rates of distress and burnout in healthcare professionals all over the world. This is just one such study. So this is from Verona in Italy. Verona experienced a horrendous burden of COVID-19 disease, and very high rates of burnout were detected in their frontline staff in intensive care, in their junior doctors, and in their nurses. But staff in many, many countries have experienced relentless workloads. They have lost colleagues to COVID. Resources such as beds, oxygen, and PPE have at times been completely overwhelmed, and heart-wrenching clinical decisions have had to be made. Many staff have held the hands of patients dying alone without their families present. The pandemic is still unfolding. We don't know when or how it's going to end. There have been some benefits in that there have been global collaborations, for example, in vaccine development and in research and treatments. Governments have had to be agile and flexible and innovative, and they've had to improve public health strategies on the run and ramp up communication. However, global health inequities have also been made glaringly obvious. For example, in vaccination rates in low-income countries. So you can see almost the entire continent of Africa, parts of the Middle East and the Far East, and parts of South America have dismally low vaccination rates compared to China, Australia, and the Americas and so on, and Europe, obviously. So there has been a demonstrated profound impact globally on mental health, including increasing burnout in healthcare professionals and ancillary staff. Obviously, an individualized approach is not going to be feasible with the number of staff that are involved. And addressing this was going to need to be a priority for all governments in the years to come, as well as institutions and professional bodies. If you are interested, I'm a great believer that in personal stories, I think they're very powerful. These are some powerful personal stories that may resonate with you. Thank you for your attention, and goodbye from Australia.